Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you again for attending our webinar series at Just CRS. Today we are privileged to have you here with Dr. Muhammad Madi from the Hashemite University to talk about and take us through this interesting webinar, Advances in Pain Neuroscience and Pain Education. So we can start this webinar. Just want to note that Just CRS is a project that is funded by Erasmus Plus program in the European Union. We started a master program in clinical rehabilitation for both OTs and PTs at Just, and this is the product of this master program. Also, I would like to invite you for the rest of the webinars today and tomorrow, and also to enroll in Maharat platform, which is courtesy of Just e-learning center and Jordan University of Science and Technology. It's for free for all therapists to attend. So thank you, Dr. Muhammad Madi, for presenting, and let's start.
Thank you, Dr. Nazal, for the lovely introduction. And I would like to thank you all for joining us today. Today we'll be talking about some recent advances in pain neuroscience, and we will end up with talking a little bit about how pain education can change the way our patients perceive their pain. So we know that pain is one of the most common reasons people seek care from a physiotherapist. Pain is always subjective. It is always real. While a person's pain experience is not visible to the observer, this doesn't indicate that pain is imaginary. So in this webinar, we will examine contemporary understanding of pain, how it's processed, what happens in the nervous system, how it becomes a persistent problem, and what we can do about it. During the webinar, we will share some amazing pain stories that are expected to change the way you think about pain. So to start, I am Muhammad Madi, Assistant Professor at the Hashemite University. I am a member of the Jordanian Society for Physiotherapy and an active member in the International Association for the Study of Pain. And I will take you throughout this learning journey. I am a graduate of the University of Jordan. I did my master degree at the Center for Musculoskeletal Studies in Australia, in the University of Western Australia. And I did my PhD in the United Kingdom at the University of Birmingham. And this webinar is brought to you by Jordan University of Science and Technology Clinical Rehabilitation Science Program, a European Union funded project through Erasmus Plus program that supports the modernization of higher education in the EU and partner countries. So during this learning journey, I will be talking about some definition related to pain. First, we will begin by some definition, then we will be talking about amazing pain stories that might make you gasp and rethink about pain experiences. Then we will examine contemporary theoretical understanding of pain, the origin of pain, and the anatomy of nervous system. Then we will be examining why pain persists. Specifically, we will be talking about peripheral and central sensitization processes. And finally, we will talk about what can we do to manage our patient who suffer from persistent pain. So let's kick off with some definition related to pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage, or described in terms of such damage. So inherent in this definition is the underlying premise that pain doesn't have to be associated with observable tissue damage or have to be detectable, or that we have to know the underlying cause. And we can notice from this definition that pain is a complex experience. It is a multidimensional, involving not only the sensation of pain, but also the emotional experience associated with it. And most importantly, that pain is subjective. And if it is described by our patient, then pain is real. So this definition is a widely used definition that stood against the test of time, with a huge amount of research that have been published since 1979, since this definition was conceptualized. So this definition remains the most widely used definition. And this international definition is used by diverse groups across the world. Nonetheless, just recently, almost at the end of last year, the International Association for the Study of Pain themselves proposed a new, slightly different definition of pain. It was open for public comment up to November last year. Commenting on that definition is now closed, and we are waiting for the consensus on whether we agree on this new definition or not. We need to differentiate between the International Association for the Study of Pain definition and the definition that we found in the International Classification of Function. In that definition, pain is a sensation of unpleasant feeling, indicating potential or actual tissue damage to some body structure, and includes sensation of generalized or localized pain in one or more body parts. Pain in dermatome, stabbing pain, burning pain, dull pain, aching pain, and impairment such as myalgia, analgesia, and hyperalgesia. We can notice that in this definition, it is close to the definition of the International Association for the Study of Pain, but it's not really identical. Specifically, this definition implies a close relationship between the sensation of pain and the presence of noxious stimulus. And by noxious stimulus, I mean a danger or a painful stimulus that need to be observable from a third person. So you need, as a therapist, using the international classification of function definition, you need to observe that tissue damage in order to judge whether your patient have pain or not. Whereas in the International Association for the Study of Pain definition, pain is always reported by or from the patient perspective. And we need to distinguish between acute and chronic pain. Pain can be referred to as either acute or chronic pain. The distinct difference exists between those two pain conditions that should be recognized. Specifically, we know that acute pain occurs as a direct result of tissue damage or potential tissue damage, and it is a symptom. As such, it has a well-defined time of onset with a clear pathology, and physiologically, this acute pain serves to protect us from tissue damage. And if tissue damage has occurred, to allow time for healing. And we know that acute pain requires clinical treatment that usually results from observable tissue damage, including any injury, ligamentous injury, for example, surgery, procedures such as wound debridement. And it needs to be adequately treated, and sometimes by pharmacological or non-pharmacological treatments that aim or directed at the peripheral tissue. Examples of these drugs, as we know, non-steroidal anti-inflammatory drugs, or example of physiotherapeutic modalities, we usually use ice to reduce the amount of inflammation and consequently reduce the amount of pain that our patients suffer. On the other hand, we know that chronic pain is not protective and does not always serve a biological purpose. Pain can be considered chronic if it lasts for more than 3 months. And this is the recent or the most recent criteria for recognizing chronic pain. It has to last for 3 months to be called or referred to as chronic pain. So this definition was proposed by the International Association for the Study of Pain for the use by the World Health Organization. And this 3 month is arbitrary cutoff point. Previously, pain was considered chronic if it outlasts tissue healing time, if the impairment is greater than would be expected from physical finding or injury, or pain occurs in the absence of identifiable tissue damage. So these are the previous definition of chronic pain, but now the definition approved by World Health Organization in the International Classification of Disease, in the 11th version of that classification, that the only definition of pain is that the only definition of chronic pain is that pain lasts for 3 months. And this leads us to think about chronic pain as a disease entity. What we mean by disease entity is that it is a pathological process that the patient has signs and symptoms related to this pain, and it has underlying pathological processes. In order to distinguish between the cases that chronic pain is indeed a chronic pathology or a disease entity, and when chronic pain is a secondary to other pathology, the International Association for the Study of Pain had a consensus meeting and ended up with distinguishing between some condition, and it was called chronic primary pain condition and chronic secondary pain condition. In chronic primary pain syndrome, pain can be conceived as a disease entity. It is defined as pain in one or more anatomical regions that persists or recurs for longer than 3 months and cannot be better accounted for by another chronic pain condition, and is associated with significant emotional distress or functional disability. These include interference with activities of daily living and participation in social roles. The emotional distress can take many forms, such as demoralization, having a depressed mood, anxiety, a sense of anger, or a sense of frustration. So there are 5 chronic primary pain syndromes. The first one is chronic widespread pain, such as fibromyalgia, complex regional pain syndrome, type 1, previously known as reflex sympathetic dystrophy, and type 2, previously known as causalgia, chronic primary headache or orofacial pain, such as migraine, chronic visceral pain, such as irritable bowel syndrome, and chronic primary musculoskeletal pain, such as chronic primary low back pain, which we know as non-specific low back pain. On the other hand, in chronic secondary pain syndrome, pain is initially manifests itself as a symptom of another disease, such as cancer, work accident, diabetic neuropathy, rheumatoid arthritis. This classification has a huge implication in terms of differential diagnosis and management approach. This definition or classification of chronic pain into primary and secondary is approved in the 11th version of the International Classification of Disease, and is expected to improve research reports on chronic pain by having a more precise and adequate coding process, as well as it will help in patient management through better diagnostic classification. In the next part of this webinar, I will be talking about some amazing pain story that would highlight the variability in relationship between tissue damage and pain. So we will learn here some amazing stories that would demonstrate a lack of relationship between the insult to tissue and the magnitude of pain experienced by our patient. By drawing on these cases, hopefully we will end up with a conclusion that pain is a multidimensional experience, that tissue damage is only one component of this experience, or what we refer to as nociceptive process. The first thing that you need to know or communicate with your patient is that the amount of patient that you experience does not necessarily relate to the amount of tissue damage that you have sustained. There have been many accounts of patients sustaining serious injuries that would be expected to be extremely painful, but it wasn't. We know that severe injury creates lots of nociceptive signals that goes into the brain, but these do not necessarily result in pain. So we will examine the reason for this at a later point. But for the time being, let's look at these amazing stories. We know that there are many stories of wartime or from wartime. For example, let's take World War II. There is a report of a veteran who had some routine chest X-ray done to him, and they revealed a bullet that was lodged in his neck for 60 years. Imagine that, for 60 years, he never knew that there is a bullet in his neck, and in spite of the tissue damage, he didn't feel pain. And there are many stories of soldiers in wartime who have a severe injury, even some of them losing their limbs, yet they report little or no pain, and some of them even didn't need any analgesia or any pain medication. And we have stories of severely burned people that have run back into burning houses to save their children or others' children. And there is another common example of extreme force on the body without causing pain. We know, I'm sure most of you love soccer games, and we know that a football player who scores a significant goal is likely to have his entire team jump on him. Imagine that, a weight of nearly a ton, yet this patient will always jump up smiling and keep playing, often better than before. Imagine that if the same football team jump on top of you while you are walking down the street. In this instance, if you sustained a minor injury, it will be sufficient to lead you in a life of chronic pain. And we know something about hypnosis, which is a fascinating experience. There are many records of people who have undergone major surgeries while hypnotized. Imagine that. They didn't receive any medical anesthesia, and they had surgeries without any analgesia, just with hypnosis, and they didn't feel pain. So how can this be possible? Nociceptors in the tissue would still be sending danger messages as the surgeon would cut them or cut the skin and cut the muscle, but they still do not have or does not feel pain. So hopefully, as you can see, in those situations, pain is at its maximum or should be at its maximum, but it wasn't. And there is a wise professor that used to say, the worst of injuries are usually the least painful. And there is another story, a report in the United States of America described a construction worker who had unknowingly shot himself with in the head with a nail gun and was not aware of his injury. He perceived this injury as a toothache and went to his dentist after 6 days. Imagine that. And lo and behold, a nail was found in his head. So imagine that. He wasn't completely unaware of the injury, and he attributed the sensation to something that is somehow familiar to him, familiar to that source. He attributed this pain to a toothache. There are lots of other examples, such as soldier losing their limbs, as we said. The understanding was that the perception of threat had diminished so much because the soldiers were returning home rather than facing another day of surviving death. And we know that low back pain and headache are, in some researches, had shown that the amount of disc or nerve damage really relates to amount of pain experienced. Many of us might have a scary sounding disc bulge, even compressed nerve, yet may never have any symptom. In one study, it was reported that 81% of asymptomatic patients have evidence of bulging disc at some spinal level. Moreover, abnormal lumbar anatomy is not strongly linked to the severity of symptom. This can be a bit frightening, but it's really quite relieving when we understand when we understand pain. Many changes in the tissue are just normal, part of being alive, and do not have to hurt. What's more, these changes don't necessarily have to stop anyone leading a very functional and active life. So it is very likely that an X-ray of an older person's spine will reveal changes which could be considered or can be described as arthritic changes or degenerative changes, yet they can still function very well. And some of those patients don't really suffer from pain. Simply put, no pain, it means that these changes in tissue are not perceived by the brain as a threat. More about these amazing stories, we know about paper cut. So the opposite is true. You might have, in some occasions, that you feel severe pain from a minor injury. Look at paper cut. It's not deep. There is not much damage, but it really hurts. It stings. It makes you annoyed. And you can't believe that a paper cut could hurt you that much. And there is another story of a builder, aged 29, that came into accident in emergency department, having jumped down the ladder into a 5-inch nail. The smallest movement in his shoe was really painful. The doctor in the emergency department needed to sedate him with very strong analgesic. If you're familiar with fentanyl, the nail was then pulled from his shoe to find out that the nail only penetrated between his toes. His foot was totally and entirely uninjured. Let this story sink in. Think about it. No tissue injury, yet this person had severe pain. And there is a well-reported syndrome that is called Covade syndrome, in which the father experienced labor pain. And sometimes some of the pain that the mother feel or suffer from during pregnancy. In some societies, they think that a father who displays this pain is believed to be a better father. And we know that low back pain occur when lumbar anatomy is completely normal. And we talked about non-specific low back pain, primary chronic pain pathologies, where there's no real radiographic or MRI changes. And this accounts to almost 80% to 90% of population. So people can suffer from pain without observable tissue damage. So obviously what's happening in your tissue is just only one part of the amazing pain experience. If you have other stories, please share them and we can discuss them at the end of this webinar. What we can learn from these stories is that what's happening in your tissue is just one part of this of the pain experience. Pain depends on many different factors. We know that the brain decides whether something hurts or not 100% of time with no exceptions. Such assessment made by the brain based on deciding whether you are in danger and you need to take action, and consequently it produces pain, or that you are not actually in a danger and consequently it will not produce pain. Some of these factors that ignite pain are related to the context, pain expectations, and even therapist expectations, and we will talk about these. So in terms of pain and context and information, we know that these information coming from the senses, such as vision, touch, these all information are evaluated by the nervous system, such evaluation involves complex memory, reasoning, emotional processes, and must include consideration of the potential consequences of a response. What should I do at this particular moment? So this makes the context of the pain is really critical to understanding the pain experience. For example, research showed that exactly the same minor finger injury will cause more pain in a professional violinist than a professional dancer, because we know that the finger damage is perceived to have a greater threat to the violinist. He uses it to perform. The ability to play the violin is significant for the violinist likelihood and identity. Even more, some research reports suggest that the injury will cause more pain if it involves the left hand than the right hand. And I want you all to think about that. Why is that? And maybe leave some comments in the chat box. This makes so much sense. I won't give you the answer now, but we can see from that the exact injury can produce different output, different level of pain. This is related to the context of pain. In an amazing experiment, it was found that a painful stimulus will hurt more if you are told it is hot than if you are told it is cold. In this study, a painful stimulus was placed on the hand while manipulating the evaluation of context, which was showing the participants a red color, which indicate hotness or a possibility of more tissue damage, or a blue color, which indicate coldness or less tissue damaging visual cue. Pain was rated as more intense and the stimulus as hotter when the subject looked at the red cue stimulus than when they didn't. In another example, participants placed their head in a sham stimulator, and they were told that the current would run through their head and pain increased in line with the instructed intensity of the stimulation. So imagine that there is no electricity running, just the patient is observing the knob turning up, and when they observe that, they would report that they have more and more pain. Think about that for a moment. And imagine that you stepped on a nail. When you step on a nail in the garden, it may or may not hurt immediately. The brain has to decide whether pain is the best thing you need to do at that moment. There are of course other influences that may exist at the time, including the possibility that you need to avoid other nails, so you shouldn't feel pain at that particular moment. The fear of serious damage of infection, and this may lead you to a sense of more pain, or maybe you need to protect maybe if you step on a nail around children, you will not feel pain because you want to protect other children around you from stepping on other nails that probably around, and it probably would be or it would probably will not lead to any pain, especially if you observed a snake, for example, that is lying close to your foot. So with some pain experiences that involve tissue damage, there will always be varying emotional content. In pain experiences such as grief, rejection from loved one, where there is a high emotional content, there will still be physical issues such as changes in the muscle tension and altered cellular healing. In a situation, for example, in a situation where a man has had a work injury, for example, from lifting a box or falling down, possibly his pain state would be greater in order maybe to get some sick leave or some compensation. So to move on, to effectively deal with pain, it is important for us to identify the contextual cues that ignite the pain experience. Examples of such ignition cues include maybe an annoying boss. You never have pain except when your boss is around you. But if you are playing, let's say, cards with your friend, you will not feel your low back pain, for example. But when you are at work and your boss coming asking you for some job to do, you will immediately start to feel pain. Pain in the office is very common. It may worse when your boss is present, depending on the relationship with your boss. If you like your boss, when you see him coming, if you have a good relationship with him, maybe this won't change your perception to your low back pain, for example. Another example, we know that a pimple appearing on your face or an acne just before a job interview would be very painful compared to occasions where you don't have a job interview or have to see somebody important to you. Pain also depends on the perceived cues. For example, post-breast surgery, some patients attribute pain due to returning cancer. They may be misinformed. They don't know whether this pain may be normal due to tissue restriction. Maybe they attribute this to a returning cancer, and it will help, and it will hurt even more. And maybe we can think how these ignited cues can reflect back to our patient who suffer from musculoskeletal pain, for example. We know that lack of knowledge and understanding also create its own input and increases fear. For example, unexplained and ongoing pain and with deep injuries that the patient can't really see is totally different from skin injuries. There is an increased sense of threat in deep injuries. The more information that the patient has about the surgical procedure, even knowing that the pain after surgery is quite normal, the smaller the amount of analgesia required and the length of hospital stays. And this is proved by some researchers. Their hospital stay will be even shorter. The amount of pain a person experiences is influenced by who else around him. Maybe if you are surrounded by beloved ones, you won't feel pain. In one pain experiment, males have been shown to have higher pain threshold if tested by females, also when accompanied by their spouse. So if in a pain experiment, during this experiment, if your wife is present, usually you would have a higher pain threshold. So the conclusion is that if these sensory cues increase pain, won't other cues decrease pain? Think about that. The things you do, the things you say, the things you believe in, the places that you go to, what happens to your body, what do you hear about you or about the pain, what do you smell or even touch may change the way you experience pain. We know that the perception of a pain relief also rely on context. So patient recovery also rely on context. Patient expectation is their belief of what will occur, what they desire to occur, or what they believe should occur. We know from some studies that acupuncture can reduce pain, but it doesn't always work. It is thought that acupuncture works best if it is performed by a Chinese man on a Chinese woman in China, and worst outcome will be obtained if it is performed by a non-Chinese woman on a Chinese man outside of China. So imagine that. And we know that the shape of the tablet that the patient take for analgesia, for example, plays a huge part in the effectiveness of the drug. We know that from research that transparent capsules with colored beads work better than capsules with white beads, which work better than colored tablets, which work better than square tablets with their corner missing, and which work better than round tablets. So imagine that the shape of the tablet that you take for analgesia can change the amount, it can be changed, or the amount of your pain can be changed by the shape of the capsule or the tablet you take. In here, we will examine some studies that demonstrated how expectation as an indicator of what the patient believes will occur can play a role in the magnitude of pain. These expectations are known to influence the response to treatment, and at certain time, it supersede the amount or the specific effects of the treatment. For example, in one study, 135 participants with low back pain were randomly assigned to receive acupuncture or massage. Participants with greater expectation for acupuncture receiving acupuncture did significantly better than those with greater expectation for acupuncture, but they received massage, and vice versa. And there is a study by Bishop who performed a secondary analysis of 140 participants with neck pain. They randomly assigned those patients to receive spinal manipulation or exercise, and at 1 month, significant association was observed between improvement in global rating of change scores that I feel much improved if the patient expectation was a complete relief. And we know from one study that lidocaine, which is an anesthetic, it was observed that lidocaine to be more effective when it was given with an expectation of benefit than it was given without an expectation of benefit. The same effect was observed in patients with irritable bowel syndrome undergoing rectal distension procedures. When those patients were given oral lidocaine, rectal lidocaine, or placebo, there was a cue given to the patient, a pain relieving cue. They were told the agent you have or the agent you have just been given is known to significantly reduce pain in some patient, and this is the placebo condition. And some patients were told that the agent you have just been given is known to significantly increase the pain in some patient. And surprisingly, during examination, findings suggest that the nocebo condition, those patients who were told that this might actually worsen condition in some patient, resulted in a slightly higher pain rating during the procedure and during the testing of the skin. So other studies like these indicate that the patient expectation for benefit from a particular intervention might play an important part in the delivery and the outcome of that intervention. So the 17th century famous philosopher Francis Bacon maybe was correct when he wrote that what a man had rather were true, he more readily believes. We can talk about lots and lots of research findings. The conclusion will remain the same, that the experience of pain is about protection. When the brain concludes that you need to be protected, it will produce pain. When it decides that there is no need for protection, pain will not be present. I hope that you would reflect back on these stories, the stories of your patient, to think whether this scale of protection exists or not. This forces us to change the language. The language we use when we examine pain. Some terms that makes no sense are still often used when we talk or write about pain. This slide demonstrates some of these terms and the terms that we believe should be used and is more accurate. So in terms of pain stimulus, we shouldn't refer to any external stimulus as a pain stimulus. It should be referred to as noxious stimulus or danger stimulus or a painful stimulus, because it may or may not end up with causing pain. Pain receptor or pain ending there is no such thing as a pain receptor, it should be called nociceptors or danger detectors. And the same goes for example, descending pain facilitation. It shouldn't be called pain facilitation. It should be referred to as pronociceptive mechanism. Next, we will examine some of the most prevailing theories about pain in an attempt to explain the experience of pain. So we will talk about the widely known gate control theory, the neuromatrix theory, the body cortical matrix, and the body cortical matrix theory. There are many other theories that you can find using this link. So gate control theory of pain. This is a theory that most of us are familiar with, since it is used to explain many of our treatment. Melzack and Wall suggest that there is a specialized nerve ending termed nociceptors, whose response is modulated in the dorsal horn of the spinal cord. Inputs from large diameter afferent or nociceptors and small diameter afferent nociceptors are gated in the spinal cord. So inputs from large diameter afferent non-nociceptors and small diameters afferent nociceptors are gated in the spinal cord. These two inputs converge on substantia keratinosa neuron in the dorsal horn of the spinal cord, as well as what we called a T cell. The theory suggests that there is a balance between large and small diameter afferent inputs that under normal condition favors the inhibition system, and thus there is no pain experience. Input from nociceptors inhibit the substantia keratinosa neuron, allowing the T cell to fire, which will open the gate and thus results in pain. This theory further suggests that increasing input from large diameter input result in a closing of the gate by increasing the firing rate of substantia keratinosa neuron, which inhibit nociceptor activity and subsequently decrease the firing of T cell, which result in reduction of pain. In addition, this theory proposed that the system is under control of supraspinal sites that could further modulate pain. However, many criticize this theory since its premise is oversimplify the pain experience, and several tenets of the original theory did not hold upon new research. Examples of such criticism is depicted in this table. So we can see that while this theory suggests that nociceptors are tonically active, research have identified that nociceptors are not spontaneously active, and they fire only in response to a noxious stimulus. One other thing, that nociceptors are directly inhibitory to substantia keratinosa cell, and research suggests that nociceptors can have an excitatory role. This theory relies heavily on the concept of presynaptic inhibition. New research identified that postsynaptic mechanism responsible for inhibition in the spinal cord as well. Based on this theory, the neuromatrix theory has evolved from the gate control theory of pain. This theory proposed a large, widespread network of neurons that integrates the thalamus, cortex, the limbic system, and initially this network is genetically determined, but at later point it is shaped by external input. Wall and Melzack, they called this network the body self. So the body self network imparts a characteristic pattern of output. It was termed neurosignature, that is projected to areas in the brain for awareness of pain and output in terms of motor outputs or motor or fleeing or whatever motor output that is associated with pain. The neurosignature pattern is modulated by sensory inputs, cognitive events such as a plastic system that is modified in real time, and therefore it would result in individualized response to noxious stimulus. So it is important, therefore, to understand that pain is processed in the brain at the cortical level, where awareness of sensation occur, not at the level of receptors or what we refer to as first order neurons. So the brain consists of heavily interwoven matrix of neural, immune, vascular cells that communicate with each other via a range of electrochemical and molecular mechanism. We will call this matrix of cell a neuroimmune network. Melzack suggested that this network that evoke a particular output and neurosignature of that output. So, so he argued that pain neurosignature bifurcate or divided into producing both a perception in relation to pain. If we are talking about pain, this output would be a perception of pain and a matching motor command such as bracing, guarding, or muscle spasm, or even maybe calling a physiotherapist for treatment. Therefore, according to this theory, pain emerges once a particular set of brain cells is activated in a particular manner. And this is widely endorsed across the scientific community, the clinical, based on clinical findings, and even it became also known to lay communities. This pain neurosignature, sometimes some authors such as Professor Lomer Mosley and David Butler refer to as pain neurotag. The more that this network of neuroimmune, this neuroimmune network is run, the stronger it becomes. The stronger it becomes, the more influential it will be. If you think of it, everything we know about pain and rehabilitation seems to fit with this theory. And the fundamental implication for how we go about understanding pain complexity can be simplified using this theory. Based on this theory, pain occurs after activation of nociceptors, but it can be maintained by continued nociceptor activation. And this pain is modified by spinal and subcortical brain stem structure. This pain also can be modified by other systems which influence the activity of nociceptors or the activity of those neurons. And this include non-neural cells such as local and circulating immune cells, hormones such as cortisol, maybe factors released from the muscle fibers such as adenosine triphosphate or ATP, or maybe lactate. And the more this combination is present, the more influential it becomes. And this, we know that this is the recipe for persistent pain. So what we would like to think that the brain is a mass of neurotags. This conceptualization provides practical biological version of the biopsychosocial model that we, or most of us, are familiar with. In doing so, it provides a working framework by which we, as clinicians, can integrate the vast amount of data that underpin the biopsychosocial model and make prediction based on using that model why the pain persists with our patient. We know that there are we suggested that the brain is a mass of neurotag. So with this picture, this is an example of one neurotag that extend between many centers in the brain, that all of these centers are associated in the protection of pain or any other experience for that matter. So for example, maybe if the amygdala was stimulated by fear or a fearful condition, it might ignite the whole neurotag, and then the patient would feel pain. In another occasion, the igniting cue may come from the hippocampus, which is responsible for memory. So maybe our patient remembered something that caused him, the whole network of neurons involved in this neurotag to fire, and then the patient would start feeling pain. So there are two broad categories for these neurotag. There is modulation neurotag, which have influence only within the brain, and there is action neurotag, which influence may extend beyond the brain. And those action neurotag, which in addition to causing pain, would lead to, for example, muscle spasm or more blood pumped into the limb to flee a danger. So these action neurotag might have influence on the muscle. It might have influence on the conscious thoughts or feeling, or any other output, such as glands involved in the fight or flight reflex. So maybe motivation to escape, maybe increased higher rate mobilization of energy stores. The endocrine system will mobilize energy stores, reduce non-essential activities for the motor system to run away. And if the patient is suffering from pain, this might lead, if you are fleeing, like for example, a beast, this might, the output of the system might be a reduction of pain. So we know that other neurotags exert their influence on only in the brain. We call them modulation neurotag, and those really related to, for example, if you are talking about a movement neurotag, the modulation is about the proprioceptive encoded data, the visually encoded data, or maybe data about the state of the body. So we know that these can be activated by any cue, stimulus, input, or any event. So we know from that that this system is modulated in real time. So maybe at a moment you would be feeling pain and you hear a good news, and out of your pain start to be less and less, or you will be out of pain because of the good news you heard, or maybe a food that is served, and you would start to have less pain. Professor Mosley and Butler, they suggested that any cue, stimulus, input, or event that provide credible evidence that you are in danger, this is most likely to produce pain. And any cue, stimulus, input, or event that provide credible evidence of safety, this would decrease the perceived amount of pain. The last theory that we will be talking about is the cortical body matrix theory, and it's really built on the neuromatrix theory. It doesn't negate any of its premises, but it does add another dimension, and it is grounded on the principle of how those neurotags that we talked about collaborate or compete with each other in order to balance between the sense of safety or the sense of danger. The main premise of this theory is that there is a matrix of thalamocortical neural loops that subserve the protection and regulation of the body and the space around it at both physiological and perceptual level. And if you think that there is too much information with this statement, let's break it down. So we know that our entire biology subserves bodily protection and this is our highest priority. And body regulation is a day-to-day ongoing version of protection. And for that matter, the experience of pain, because it's about protection and the need for your body to be protected, for you to be protected, you would feel or pain, or you wouldn't feel pain. So we know that, for example, by maintaining normal blood pressure, we maintain protection against acidity. The application, integration, and discussion of the cortical body matrix concern those processes that are driven or modulated by the brain responses. So therefore, they are processes or output that result from the activation of neurotags because they extend beyond the brain to the body. So we think about the muscles, the immune responses, the blood flow, or the consciousness. For example, the feeling of swelling. And some studies and some patients reported that patients who have osteoarthritis, when you ask them to draw their knees, they would draw it larger than it actually is. One aspect of the cortical body matrix is that it really differentiates, that what clearly differentiated from previous ideas is that the inclusion of space around the body. In a way, we tend to have our own space that immediately surround us. So some scientists call this space the peripersonal space. I wonder if some of you have watched the Fly episode of Breaking Bad series. And if you remember Walter White and the kind of adverse events that happened to him in terms of his cancer, fleeing narcos, being under threat, being under stress, all of these issues that led a simple fly that any one of us won't pay attention to. It led to him being really annoyed, being really in a painful situation. A fly we know that is more likely to trigger protective swipes or increase tactile inputs if it enter your peripersonal space, not more than that. You shouldn't be worried about a fly at the corner of your room. And this system is activated once the fly lands in your skin, not while it is away from you. So the point here is that it's not just our body tissue that is regulated or protected in real time, but it's also the peripersonal space. So when this cortical body matrix gets disturbed, some of our physiological regulation are disturbed. To give you a personal example, I have, at some points in my life, I had low back pain, which from now on then I get this pain. It is in my right side. So whenever I am sitting down, trying to do some work, preparing for some lecture, if one of my daughters just standing on my right side, I immediately feel the pain. But if they go and stand on the left side, the alarm system is not triggered, so I don't feel any pain. So think about that. Let me know if these things have ever happened to you or to your patient. The link, so at both physiological and perceptual level, and this linkage between what happens physiologically and what happens perceptually is an advanced step from the neuromatrix theory propositions that a single command bifurcate to yield a motor output and the experience that matches this motor output. The cortical body matrix theory extends that idea by suggesting a unity of the mind-body connection. It simply means that we live in one biological environment and that it is in a constant state of change, adaptation, and living. Therefore, action neurotagged outputs can produce feelings, for example, pain, thoughts, worries, happiness, words, what you say about your pain, how you perceived your pain. And this is not all, but I think you get the picture. So these action neurotags are under the influence of massive range of modulation neurotag, which all under the influence and depend on the environment, even the molecules that float around the body. So this is there is already a huge body of evidence that the feelings and physiological reaction go together. And we know from evidence that immune system can change the body, which include the neural, which include the nervous system. And we know that the nervous system can affect the immune or the activity of the immune system. So it's a two-way relationship. And one of the suggestions that we need to look at our body as a garden and at a machine at the same time. For example, evidence suggests that probiotics, which are bacteria in your gut, can impact the function of the central nervous system in both animal and human models. This includes an impact on pain processing, fatigue, or other psychological symptoms that are closely linked to pain production. So Professor Mark from Australia introduced us to this idea that we as a physiotherapist often look at our body as a machine, as a pulley, levers, electrical wiring. However, we now know that there is a shift in function that occur based on the environment around you. So I will leave you with that, to think about that. Think of the impact of the environment on how or on the amount of the pain that your patient perceive. So next we will examine, we will continue this journey by explaining why pain persists beyond the expected tissue healing time, in spite the fact that the injured tissue should have healed. And before delving into this, I want you to look at this picture. When I was in the United Kingdom, I went with my family to visit London Zoo. Before getting there, we walked Regent Park from south to north. Halfway there, we stopped observing this little square. The thing is, squares are very common in Birmingham, where I did my studies, but I decided to take this photograph when I saw how my daughters enjoyed this situation, how they sat almost there for 5 minutes, in spite of seeing many other animals on that day in London Zoo. This photograph remained my favorite. I liked it. It is personal to me. So you can imagine the meaning of it, the point in time, its uniqueness. Pain is the same. It is personal experience. So what I would like to ask you is not to think about squares. Okay, for the next few seconds or a minute, don't think about squares, please. And now, what you are thinking about, I would suspect that most likely, most of you at least think for one moment about a square. So this points out that when you continually relive an experience, relive a thought or a feeling or an emotion, it becomes much easier to recall. So whenever I'm thinking of squares, that image, that picture directly pops up into my mind. Think about that in terms of your patient, because they constantly think about their pain. So it would be much more easier for them to recollect, to think about pain, and the system become more trained into producing pain. So think about how many times a song just stuck in your head when you try to forget it. It just keeps playing and playing and playing, which if you dislike this song, or you will end up frustrated or annoyed. Remember that neurons in your prefrontal cortex or hippocampus are responsible for memory and emotion, which are part of the pain neurotag that we talked about. So activation of these neurons can activate the whole neurotag and the experience of pain, and the patient relive the experience of pain all over again. So this highlights that tissue damage is not equal or necessarily to experience pain. When I see a picture of squares now, I will instantly think of this experience with my daughter, as well as all other squares I saw in my life. Think of the patient who suffer from a low back pain, and when he comes to your clinic, he don't only recall his low back pain. He starts to talk about his neck pain, he starts to talk about his knee pain, all the pain that he suffered in his life. So in this section, I will be talking about the biology of persistent pain. We know that the brain draws upon lots of other aspects to create a complete picture of the experience in order to generate an output, such as smiling, sense of happiness, sense of sadness. These aspects include memory, includes beliefs, what you think about what the patient is thinking about, behaviors, how the patient react to it, emotions, how they feel about it, whether they feel happy or angry, the environment, what the patient think about the surrounding or the people around him, and of course the physical, whether the patient feel empowered, strong, motivated, etc. I think you get the picture by now. So in terms of nociception, nociception is a process of sensory neurons detecting danger stimuli in the tissue, and those sensory stimuli are called nociceptors. Remember that we define nociceptors as danger detectors. And those nociceptors are set off by mechanical, thermal, chemical stimuli. This is really important because when we sprain or strain tissue, when we have an inflammation or injury, or feel a significant increase or decrease in temperature on the skin, we need those nerves to send us a danger message up to the brain. Nociceptor's body is located, as we know, in the dorsal root ganglion. The peripheral and central terminals of the nociceptors are connected. The peripheral ones are connected to certain bodies that sense change in pressure, changes in temperature, or there are free nerve endings. And the central terminal is attached to the second order neuron in the spinal cord. So the nociceptor synapse in the spinal cord with the in the spinothalamic tract neuron that transmit nociceptive information to the brain. So this is really important to stress at this point, that nociceptors are sending danger messages to the brain. They are not sending pain. Nociceptors can be found in the skin, muscles, joint, in the viscera, so pretty much in every tissue in the body. Some nociceptors are normally silent, but after tissue injury, they become activated and respond to noxious stimulus. For example, one study showed that before experimental knee joint inflammation, some group 3 and 4 nociceptors do not spontaneously fire or respond to noxious knee joint movement. After the inflammation was induced, these nociceptors fire spontaneously. We know that substances released as a result of the injury may sensitize the nociceptors, allowing them to fire to lower intensity stimuli. We know that silent nociceptors initially located in joint tissue, but have since been located in the skin, in the viscera, in different body tissues. And we know that approximately 1/3 of nociceptors innervating the joint, the skin, viscera are silent and become activated after tissue damage. Once again, I need to stress out that when we are talking about nociception, the message that is sent along the nerve to the spinal cord, it says danger. It doesn't say pain. So there is 2 processes that sensitize the nervous system the sensitivity of those nociceptors to painful stimuli is modifiable. It can increase or decrease in response to a peripherally applied mechanical, thermal, or chemical stimulus. We use the term sensitization to describe those changes in nociceptive neurons after tissue injury. It is defined as an increased responsiveness of the neuron to their normal input or recruitment of responses to normally sub-threshold inputs. Specifically, peripheral sensitization refers to increased responsiveness and reduced threshold of nociceptors to stimulation of their receptive field. Many neurons and non-neural substances are capable of sensitizing those primary afferent neurons or first-order neurons. The characteristic of peripheral sensitization, many research has demonstrated that there is an increased spontaneous activity, a decrease in threshold in response to noxious stimuli, which is referred to primary hyperalgesia, an increase in responsiveness to the same noxious stimuli, and or in some occasions there might be an increase in the receptive field. And we know that silent nociceptors begin to respond to both innocuous and noxious stimuli. What we mean by innocuous stimulus is previously non-dangerous stimuli, such as touching the skin. We know that with some patients, even touching their skin can cause pain. This is referred to as allodynia. We know that with peripheral sensitization, there is increased input to the central nervous system, which further magnify the danger messages that go up to the brain and can be interpreted as, will be interpreted as pain. We know that there are different types of neurons in the dorsal horn cell. There are high threshold neurons that respond only to noxious stimulus. We have wide dynamic range neurons that respond to both noxious and innocuous stimuli. And we have low threshold neurons that only respond to innocuous stimuli. We know that sensitization of both high threshold and wide dynamic neurons occur after peripheral or local injury. And with central sensitization, the low threshold neuron, they are become active, and that's why touching the skin may become painful. So, for example, from examples from animal studies demonstrated that there is enlargement of receptive field after tissue injuries that can include the entire limb. And think about that in your, with your next patient who suffer from complex regional pain syndrome. So also in non-inflammatory model muscle, in non-inflammatory model of muscle pain, the receptive field enlarged to include the contralateral hind limb. And think about that with your patient who suffer from bilateral carpal tunnel syndrome. So this indicates that there is a bilateral hyperalgesia that was observed in this model. And interestingly, in another study, it showed out that within minutes of injecting inflammatory irritant outside the neuron receptive field, resulted in a new receptive field that included the site of injection, as well as additional sites. So think about that, and where, for example, when you test the dermatomes of your patient and you find some inconclusive finding, what is the level of this pain problem? So there might be pain outside of the receptive field of the affected neurons. And there is a huge number of studies that have been done on humans that support these findings. It has been shown that central sensitization can be initiated by inputs from sensitized nociceptors and can persist in the absence of nociceptive input. This can be explained in the context of the need for protection framework that we talked about earlier. If the protection is required, then the brain would create pain. The brain can create pain even without nociceptive stimuli. So I would like you to think and reflect on the pain stories that we talked about, specifically the study where they placed the head inside a sham stimulator. And remember that even with no current running, participants in that study reported that they had pain. So we know that thoughts, people, places can activate those pain neurotags, and pain will be felt exactly the same. So I want you to think of the implication of that on treatment, especially if with your patient, those patients who remember or start to remember their injuries. They talk about that accident that occurred 20 years from now. Since then, they don't feel the body is the same. They keep remembering those injuries. They're speaking about different body systems that they think it had a problem. So I would like to think about all of those, your patient, the stories that they tell you, and think of how you can now rethink these stories in the context of danger, safety metaphor. We talked about the immune system. Now we will expand further. We know that there is other cells other than neural cells in the central nervous system. There are the glial cell. There are 3 types of glial cell in the central nervous system: the astrocyte, oligodendrocyte, microglia. And we know that actually microglia are part of the immune system and follow the characteristics, action of and function of the immune system. Those glial cells in the central nervous system play a critical role in processing of nociceptive information. They express receptors for many neurotransmitters, including glutamate receptors that are involved in clearance. Those microglia specifically involved in clearance of neurotransmitters from the synaptic cleft. We know that activation of astrocyte and microglia occurs in many pain models, including neuropathic and inflammatory models. And we know that these cells facilitate the nociceptive processing. And we know that glial cells release a variety of neuroactive substances that are known to sensitize neuron, such as glutamate, nitric oxide, and other pro-inflammatory cytokines. We know that glial cells can also have a beneficial outcome in the central nervous system and respond and contribute to the local immune environment. These benefits include release of anti-inflammatory factors, such as interleukin-10, which restore the normal nociceptive process. So we know that the glia of central nervous system plays a significant role in both the facilitation and inhibition of nociceptive information in the central nervous system. Previously, we had an understanding about descending antinociceptive pathways, or what we call descending inhibition or antinociception. And this was previously thought to be the only thing that occur, or the only influence that the brain have on the pain pathways. But now we know that there is a balance between facilitation and inhibition. And we talked about that there are multiple nuclei in the brain that are involved in descending modulation of pain. These include the periaqueductal gray, the rostral ventromedial medulla, the dorsolateral butine tegmentum. And we know that all of these nuclei are also under the influence of higher centers, such as the cingulate cortex, the insular cortex, the prefrontal cortex, and amygdala. So as I said previously, we thought that this system is only antinociceptive, meaning that inhibit the feeling of pain. But we know that these supraspinal centers can process, facilitate, and maintain referred pain, secondary hyperalgesia, and may produce some mirror image or contralateral hyperalgesia. Think about that, as I said earlier, in your patient who have bilateral carpal tunnel syndrome, who had surgery only in one hand, but found relief or their pain decreased or maybe disappeared in the contralateral hand. And this may indicate how these descending pronociceptive pathways are really important in understanding the pain experience. Next, we will examine some possible management options, specifically those related to pain education. So we know all about these theories. What can we do? In their book, Professor Mosley and Butler included multiple pain stories that we talked about some of them today that target some that address some target concept related to pain experience. So our role as therapists is to identify those target concepts to see whether they exist in our patient, and then try to design some pain education curriculum with an overall aim of achieving behavioral change. So we want our patients to change their behavior, to change their thoughts, to change the way they perceive their pain, to think about that tissue damage, for example, is not really related or associated with the amount of pain they suffer from. So the objective would be to generate a neurotag that overpower existing pain neurotags. This, of course, based on some moderate quality studies, have been found to lead to long-lasting impact, simply because maybe the patient become generator of their own neurotag. If they understand, then whenever they feel pain, they will start to recognize the igniting cues or the stimuli that cause them to feel pain at this moment, not the way they have seen their image on MRI or because of the injury they had 30 years ago. So there is a strong scientific evidence that shows that explaining pain has an effect size on pain and disability of 70% compared to other type of intervention. This is not to suggest that you would use explaining pain as the only method of treatment, but this might lead us to think about that the remarkable effect of treatments that we commonly call placebos can be in fact attributed to the engagement in the concept of neurotags and identifying the contextual cues that surround the patient. So Professor Mosley and Butler in their book Explain Pain Supercharged suggested that our pain education curriculum should address those target concepts. These concepts we have talked about during this webinar, that pain is normal, personal, and always real. It is a subjective experience. Learning about pain can help the individual as well as the society. We know that almost 25 to 30% of population in general suffer from chronic pain at some point in their life. Pain and tissue damage are poorly related. There are danger sensors, not pain sensors. We can convey the message to our patient that pain relies on context. And from a biopsychosocial perspective, we need to start addressing this context. Another target concept that you may examine with your patient, that pain depends on a balance between danger and safety, that pain involves distributed brain activity. So it's not only the cortex, it's not only the thalamus, as we learned in our undergraduate curriculum. It is processed in different centers in the brain. So now we know that your anger, your memory can trigger pain, or in fact can relieve pain. Pain is one of many protective outputs. There are other motor outputs. So imagine, think about your patient who really understood why they feel pain, and you notice that their muscle spasm started to disappear gradually. And there are reported case studies that demonstrated that this occurs. Even some people or some patients who have some small ganglion in their at the back of their hand, at the back of their feet, these ganglion disappeared once they understood why they suffer from chronic pain, or why their pain persisted after injury. Patient need to know that we are bioplastic, and if the changes in your brain have caused you to feel such amount of pain, those you can have similar changes that will lead you out of your pain. So patient may benefit from understanding that we are bioplastic, and we need to focus on active treatment strategies which will promote recovery. By active treatment strategies, I mean that the patient take charge, take control on his treatment, meaning that he don't passively rely on our treatment. And not to confuse that with patient expectations. If the patient with some with some expectation of receiving a massage may have a huge amount of pain relief if you have done this massage for them. So in clinical practice, we talked about understanding patient expectations. We know that non-specific treatment effects such as expectation may enhance or negate the specific effect of interventions that are directed for pain. So therefore, non-specific effect of treatments such as these expectation could be an additive part to the specific treatment effect. So if we know that electrotherapy, for example, works on gate control theory, now we know that patient expectation of receiving electrotherapy, in addition to its actual treatment effect, can maximize the outcome of the session. But I want you to think, if you have a patient or who is the victim of torture, and who was electrified or as a method of a torture, I want you to think, if you suggested or decided to do electrotherapy for them, what will be the outcome of such decision? So in terms, back to expectation, we know that expectations are generally high among those who seek care, who present themselves to our physiotherapy department, which makes sense. But we know that some of our patients doesn't have a clue why their physician have referred them to physiotherapy. So those patients, they have no idea why they are here. They think that this person just sent me here. I don't know what to expect. So you need to have a frank, open dialogue, communication with them about their expectation, what they think their diagnosis is, what they think about the prognosis, about your modalities, whether it will hurt them or not, their specific treatment effect, and what should they feel during, for example, using ultrasound. And there is lots of study that examine this, but I think I need to move on. We can change patient beliefs also through the use of metaphor. These metaphors need to be installed some new ideas about pain instead of long-held conventions, that pain is a protector, not a sensation, that pain is about the future, not about the past, that pain is like a little angel that tries to make you safe, not a devil that tells you what's wrong in your body. We can use metaphors such as those described by Professor Mosley, that changes in your spine are cases of time. And we know cases, a case is something nice that any one of us expect, would feel safe, would feel happy to receive, like a hug, for example. So maybe we would use another metaphor, like we grow like trees, and using this metaphor, we highlight to the patient that maybe those changes in your spine, maybe they are quite normal, and they are normal part of getting old, and it doesn't have to be to cause pain or to be a problem for you. There is lots and lots of metaphors that you can find, and there is one website, Noi Group website. They post lots of other metaphors that you might check. So we can change how the patient perceive their brain activity. We know the metaphor of, we know that the brain is always considering the risk of danger, safety. We can ask the patient to look at this optical illusion and ask them, what do they see? Most of us would see that those lines are inclined, but even if I tell the patient that those lines are parallel, but because of the way that the black boxes are stacked on top of each other, you see these lines as inclined. And from this, if the patient convinced that you can deceive the brain, we can move on telling them that likewise, you may perceive your spine as crooked, for example, as you are twisted, your joint is enlarged, but it's actually, you imagine that this would be a problem. And the last shape, maybe you would have your patient look at these different, at this shape and ask them which shape is larger. And we know that although shape P appears to be the largest, we can convey the message that sometimes the brain thinks that the injury is greater than it actually is due to previous experiences. And this perception of bone injury may amplify the feeling of pain. So using these metaphors, using these shapes, using these analogies, these stories, we may start to shift the thinking of our patient away from body damage equals pain and towards, I need to know my context. I need to know what factors really causing me to suffer from pain at this particular moment. Remember that with some condition, there is a specific diagnosis that is possible. Don't miss out these cases because of what you have learned in this webinar, what you have learned about central and peripheral sensitization. There is lots of patients who present with acute low back pain, acute neck pain, that you might use, still use the biomedical model with them, identify the tissue damage and treat them accordingly. But we have to be careful if those patients with acute injuries start to manifest or demonstrate some signs of that they might move into chronicity, such as catastrophizing their pain, such as fear avoidance, such as anxiety, we might start to administer some pain education. At the end, I would like to thank you for attending this webinar, and I'm ready to answer. These are the resources and reference for the lecture. And if you have any question, I would be more than happy to answer.
Thank you, Dr. Mohammed Madi, for your fascinating presentation and very engaging. I like the drawings. And
these are
Arabic, so I love it.
These are my students' drawing.
Perfect. So if there is any question, we will take it. Otherwise, I can write it in the chat or raise your hand, so we can let you ask the questions. Otherwise, again, thank you so much for attending, and it's a wonderful presentation, and Again, these webinars are a series of webinars funded and supported by JUST CRS, which is the master program in clinical rehabilitation sciences that is funded by the European Union Erasmus+. And this webinar is brought to you by also courtesy of Maharat platform, which is a new free electronic platform for the Arabic learners. And we are posting a lot of webinars and online courses in the coming days. So please stay tuned and enroll. Thank you so much, Dr. Muhammad. If you'd like to say anything at the end.
Thank you for having me. I would like to thank everybody for attending this webinar. Should they have any question, I would be more than happy for them to contact me to answer any concerns, any questions about the topic of this webinar.
Perfect. Thank you so much.